My name's Dr. Eric Lai. I'm a board certified private practice nephrologist, and I practice in California currently. So, yeah, we can basically define what is IgA nephropathy first for people who don't know. It's actually the most common, what we call glomerulonephritis in the world. Glomerulonephritis is kind of a rare kidney disease that nephrologists treat. And IgA nephropathy is actually the most common of the rare diseases we treat, if you can think of it that way. The pathophysiology has definitely been researched extensively, and there's been a lot of breakthroughs. For some reason, it's considered an autoimmune condition where there's aberrant immunoglobulins called IgA that basically get deposited in the kidney and cause inflammatory injury inside the kidney. And over time, those immunoglobulin IgA deposits in the kidney causing inflammation can lead to progressive scarring and damage in the kidneys, leading to end stage kidney disease or requiring dialysis or a transplant. So it definitely is not always a benign disease. It can be pretty indolent and slowly progressive. So that's why it's very important that it's caught early, because what's great about IgA nephropathy nowadays is there's so many newly approved therapies that the FDA has approved recently to treat this condition. Whereas, 20 years ago, we had very limited options. It's immune dysregulation. So there's an aberrant immunoglobulin A. So it's an antibody, and antibodies are very important to fight off infection. They serve a purpose. And for some reason, they've teased out that there's an aberrant immunoglobulin A molecule, Gd-IgA1, or poorly galactosylated IgA, which is very technical. But it's basically only a certain subset of the population produce this aberrant immunoglobulin molecule. And then our immune system doesn't recognize it. It thinks it's something foreign. So, what happens when our immune system detects something foreign, like a virus or bacteria? It starts mounting an immune response, right? So, that happens, unfortunately. And I do feel like there's an autoimmune component to IgA nephropathy. I think patients have come up to me and been like, what did I do wrong to get this condition, right? It's not like diabetes or high blood pressure, some other kind of lifestyle comorbidities where a poor diet, lack of exercise can lead to diabetes or obesity. For IgA nephropathy, it's completely different. It's not necessarily a lifestyle change that triggered the IgA nephropathy. Oftentimes, their genetic predisposition and their autoimmunity that goes awry that causes this condition. Going back to kind of what triggers IgA nephropathy, you're talking about the common presentation. So let's say there's a person who unfortunately develops a cold and gets the virus, and just a head cold, coughing, sneezing. And then that person all of a sudden develops very dark colored urine, tea colored or Coca Cola colored, while they have this head cold or sore throat. That is a quite common presentation for IgA nephropathy, because immunoglobulin A or IgA, that antibody, is a very important defense mechanism at the mucosal barrier. So you can think about the inner lining of your nose, your throat, your esophagus, your gastrointestinal lining. That's all mucosa exposed to external environment. And that IgA molecule or immunoglobulin A is very important to combat any foreign pathogens that can potentially invade our bodies. But with IgA nephropathy, these patients have aberrant or abnormal IgA molecules that get formed oftentimes after these viral upper respiratory tract infections or sore throats. And that's when they develop that very dark colored urine. And that dark colored urine is actually red blood cells leaking out of their kidney. It's called hematuria. That is indicative of an inflammatory injury that is happening inside the kidney. There's a very wide spectrum of IgA, how IgA nephropathy presents. It can be extremely benign. Patients can just have what's called microscopic hematuria with a couple red blood cells in the urine, but they don't have what's called proteinuria, which is protein leaking out of their kidney. But it's those subset of patients, which I have a couple, it's very benign. So they don't have a lot of protein leaking out of their kidney. They just had some red blood cells. They have preserved kidney function. And overall, they have a good kidney prognosis. So that's one end of the spectrum. And then you have the other end of the spectrum where they can present quite dramatically, even with a very severe form of autoimmune attack in the kidney called crescentic glomerulonephritis, which can be rapidly progressive and leads to end-stage kidney failure very quickly. We call that rapidly progressive glomerulonephritis. And IgA can definitely be one of the triggers for that. You have to control their inflammatory injury very quickly with immunosuppressants to help their kidney, to prevent their kidney from getting worse in those instances. And then in the middle are the majority of IgA nephropathy patients. What puts you at risk for progression to IgA nephropathy? Our thinking nowadays is it really is dependent on your degree of proteinuria. That is a very important kidney prognostic biomarker we have. I wish we had more biomarkers to track your kidney prognosis, but that kind of stratifies whether your IgA nephropathy will get worse over time or will remain relatively stable or in remission or quiescent based on the degree of proteinuria. Because if you think about it, with the coffee pot analogy, more damage to that paper coffee filter, what's going to happen? More coffee grounds are going to spill out into the coffee pot. And over time, the kidney gets completely damaged. You won't have any more paper coffee filter left if it all gets damaged and chewed up, right? So the proteinuria of an IgA nephropathy patient is definitely tracked by all nephrologists. And it kind of gives us a gauge of how well we're doing at treating their disease and also to kind of gauge their overall kidney prognosis if they're going to progress or if they're going to remain stable or get better. How you risk stratify these patients is through what we call proteinuria. Proteinuria is when protein leaks out of the kidney into the urine. And a symptom of proteinuria can be what's called foamy urine. Like if you pee and you see a lot of bubbles or foam in the toilet bowl in the urine, that's indicative of proteinuria, protein leaking out into the urine. That is an abnormal sign for kidney health. What I always like to say with patients is to give them an analogy. So let's say you want to brew a nice big pot of black drip coffee. So what are the steps for that? You have your paper coffee filter, right? You put it on top in that compartment, and then you put your coffee grounds on top, right? You put the hot water on top, and then down in the coffee pot will be a nice big pot of black coffee, luckily with no coffee grounds, right? Unfortunately, if that paper coffee filter somehow got damaged, what do you think would happen to those coffee grounds on top? They would start spilling out into the coffee pot. So, if you can think of the kidney as a very sophisticated filtration organ, honestly, just kind of like that, a sophisticated brewing coffee machine, where you can imagine the top half of the coffee machine is blood, and the coffee grounds is actually the protein in the blood. And the kidney is the paper coffee filter, right? And then at the bottom in the coffee pot, you have your urine, right? This is an analogy. I know it sounds gross, but I just want to give you that image of how sophisticated the kidney is in terms of filtering blood to produce urine. Basically, the kidney is a very elegant filtration organ that filters blood of all the toxins, retains certain electrolytes, and all of those waste products gets eliminated through urine. So if you can think about anything that damages the kidney, diabetes, high blood pressure, IgA nephropathy, just remember this analogy where somehow that paper coffee filter, when you're brewing black drip coffee, if someone were to get like scissors or a knife and started punching holes inside that paper coffee filter, what would happen with the coffee grounds? It would start seeping out into the coffee pot. And that's what proteinuria is, if you think about it that way. Proteinuria is definitely something that we monitor. And there's two ways to measure proteinuria. One is quite cumbersome. You have to collect a 24-hour urine collection, which is a whole days of urine in a jug. And that's actually more accurate to quantify the degree of proteinuria, but obviously very, very inconvenient, especially if you're a working professional. But oftentimes, nephrologists order what's called the random spot urine protein creatinine ratio or random spot microalbumin creatinine ratio. And the patient just needs to give a urine specimen at the lab and based on that, they can kind of estimate how much protein the patient is spilling in a 24-hour period just based on that random spot specimen. You also mentioned other things that we monitor. Hematuria is also, some nephrologists monitor that. So the degree of red blood cells spilling out into the urine could be indicative of ongoing inflammation inside the kidney. So if you can get rid of those red blood cells in the urine, that might indicate to you that you're doing your job right, you're treating the patient appropriately to decrease the inflammation happening inside the kidney. And then we order blood tests to determine their degree of kidney function. And the important blood test there is creatinine, an estimated glomerular filtration rate, or EGFR. Those two metrics are very important for nephrologists and primary care physicians because it kind of uh, classifies the patient in various stages of chronic kidney disease, which can range from 1 to 5. So, dependent on their EGFR, that's kind of like your kidney percentage, how well your kidney's working. And so, if you had an EGFR of let's say 50, that would put you in stage 3 kidney disease. If you had an EGFR less than 30, that would be stage 4, and less than 15, 1.5, would be stage 5. These patients usually need dialysis or a kidney transplant. That's the end stage of kidney failure. So obviously, you want to catch patients at the earlier stage of chronic kidney disease, which is EGFR not 90 or greater, up until EGFR 60, right? Because they have preserved kidney function. Unfortunately, I do have patients that present to my office that are already EGFR kidney percentage like 20 or 25%. When I see that, I'm very disheartened because I know most likely, if we're talking about an IgA nephropathy patient, that disease process has been happening for a while, and their kidney probably most likely is already scarred. There's not much you can do at that point. And sometimes you just need to prepare them for dialysis or a kidney transplant because, at that point, their kidney's already scarred once they reach latter stages of chronic kidney disease, stage 4, stage 5, right? That's unfortunately the problem with yearly annual physicals and checkups. Your doctor ordered a lipid panel, your cholesterol, basic labs, right? But If you think about it, have they ever tested your urine if you don't bring it up? It's not part of the routine annual physical. Other countries, it's mandated that they test annually their urine, especially for protein, blood. These are important urinary biomarkers that can be indicative of occult IgA nephropathy lingering in the background. I don't know why the screening in America, we don't test urine more routinely. Like you just mentioned, a primary care doctor will probably only order urine tests if the patient brings it up, especially if they have infectious symptoms like burning or pain when they pee. But obviously, if they have tea-colored or Coca-Cola colored urine, I would hope that most of the doctors would order a urine test just to see if there's any blood in the urine or anything else going on. A lot of non-nephrologists, they just rely on blood tests to determine how well their kidney health is. But that leaves a very incomplete picture. As I said, the blood tests will detect your creatinine, which is your kidney metric, and your EGFR, your kidney more or less percentage. But by the time those get out of range on your blood tests, it's already too late for a lot of these disease processes. The damage has already been done when their EGFR is down to 35, right? An earlier sign of kidney damage is testing the urine through what we just mentioned, detecting blood in the urine, detecting protein in the urine. Any persistent proteinuria, even despite having normal, quote unquote, normal blood creatinine, quote unquote, normal EGFR, if there's persistent proteinuria, that should definitely be referred to a nephrologist ASAP. I think in the past, a lot of primary care physicians for CKD stages 1 through 3, they would just manage it on their own, right? They don't need to see a kidney doctor or nephrologist until they reach maybe CKD stage 3B or higher. CKD stage 3 is divided into A and B. B is worse, right? I personally don't agree with that because remember, if their creatinine and EGFR are normal, that doesn't get them out of the woods, right? What if they have proteinuria that persists? The patient's complaining of, oh, every time I get sick, I see Coca-Cola colored urine. My urine is so foamy and frothy. I'm developing swelling. So blood tests don't tell the full story of a patient's kidney health. You know, I really encourage primary care physicians and family physicians all over the country to really start testing the urine because if we can catch IgA nephropathy earlier, that would be great because there are so many available treatments out there right now for IgA nephropathy that a nephrologist could use to slow down the progression of their IgA nephropathy. There really should be a push nationally to include a urine testing in your annual physical. I think there is an argument that, hey, what if it's a false positive, right? False positive is like basically you detect the blood, you detect the protein, but it actually is not there. So it leads to over testing, over referral, right? But at the same token, at least for catching patients that have occult IgA nephropathy, that have blood in the urine, that have protein in the urine, and we can catch them at earlier stages of chronic kidney disease by doing more frequent urine testing. So I think that's one of the main messages I want to put out there amongst all physicians is that you can't always rely on blood tests to determine kidney health. You really need to look at the degree of protein or proteinuria to determine their kidney health. Have a common scenario I've heard. I recently went to a conference in DC, and there were some patients with IgA nephropathy there. And their presentations were pretty eye opening in that their diagnosis was delayed for many years, actually. months to years because the patient would complain of this dark tea-colored urine whenever they got sick. And, when we think of blood in the urine, oftentimes physicians think, oh, it's a kidney stone, right? So a kidney stone is not necessarily managed all the time by a nephrologist. To actually retrieve and take out a kidney stone or get it removed, it would be sent to another specialist called a urologist. Urology is a surgical specialty, and they do procedures to remove kidney stones. So oftentimes, these patients that have dark urine and the primary care doctor detects blood in the urine, they get referred to urology. Urology does further testing, which can often include a CT scan to detect any kidney stones, see if there's any structural abnormalities. Okay, great. No kidney stone. They often do what's called a cystoscopy. They use a camera to look inside the bladder to see if there's any bleeding coming from the bladder, not the kidney. Oftentimes, those are negative in these IgA nephropathy patients. And so the urologist says there's nothing urologic that is causing this blood in the urine. And, unfortunately, when I went to this conference, the diagnostic workup stopped there because the patient still had blood in the urine, dark colored urine, but it wasn't coming from the ureters, the bladder. It wasn't from a kidney stone. It was coming from the kidneys. Those filters were being damaged, right? So, there really should be a push, not only amongst primary care physicians, but amongst our urology colleagues, that if someone is referred to your practice with hematuria or blood in the urine, and you do a negative urologic workup, negative cysto, negative CT scan, no kidney stone, at that point, I think almost all those patients should be referred to a nephrologist just to make sure there's not an underlying intrinsic kidney disease like IgA nephropathy, or there's other conditions that can cause blood or protein in the urine that's contributing to that, right? So it's just one of those things where you don't want to miss this condition because there are options out there to treat it, especially if you catch them at an earlier stage. Once you reach stage 4 or higher, you know that the kidney's already scarred up, and probably putting them on therapy would cause more risks than benefit at that point. Please test the P.
Yeah.
That's my main message if you can, because blood tests are not enough, especially for primary care physicians. If you can really tag on your analysis with micro, and if a one abnormal value, okay, fair enough, it's one abnormal. But if you repeat it and it remains abnormal, at that point, that should be a trigger to refer to your local nephrologist to get it evaluated. Because the only way that IgA nephropathy is diagnosed officially is through a kidney biopsy. That's where you have to put a needle in the back of the patient and sample pieces of the kidney. That is the only way. You can't diagnose this condition through blood or urine tests. And so the only doctors ordering a kidney biopsy are usually us, the nephrologists. So please, if you detect persistent urinary abnormalities, especially hematuria, proteinuria, blood in the urine, protein in the urine that doesn't go away, despite having a normal creatinine or normal EGFR, please refer to your local nephrologist, because at that point, the patient may warrant a kidney biopsy to determine whether or not they have a glomerulonephritis like IgA nephropathy.